Okay.
ठीक है।
I guess there was some interruption in the internet connection, so I'll be repeating the last 4-5 slides again. So let's discuss the calcium channel blockers again. Now, what's the mechanism of action of calcium channel blockers? Basically, they block the calcium channels in the SA node, and as a result, what happens is the slope of the phase 4 it decreases. Ultimately, the atomicity of the SA node it decreases, right? So overall what will happen, the rate of contraction of atria and ventricles both will decrease. Apart from this, what calcium channel blockers they do is that they cause the AV nodal delay or they decrease the AV nodal conduction velocity. Refractoriness it increases, and overall what happens is the heart rate decreases. It also may suppress EADs and DADs in myocardial cells. They depress the contractility. Verapamil diltiazem, they possess a useful antiarrhythmic activity. In the next slide we'll see where these calcium channel blockers they are useful. So therapeutic uses, PSVT. PSVT is a major indication for use of calcium channel blockers. Apart from this, atrial flutter, fibrillation, ventricular tachycardias, they are an important they are important indications for use of calcium channel blockers. They are rarely given to patients in ventricular arrhythmias. Adverse effects are AV block, sinus arrest, hypotension, headache, fatigue, and constipation. These adverse effects, they are commonly reported with calcium channel blockers. Apart from this, cardiotoxic effects like bradycardia, AV block, myocardial depression, they have also been reported with calcium channel blockers. Now let's come to adenosine. Adenosine is basically what? It's a nucleoside that is present throughout our body. It is basically an agonist at alpha 1 and alpha 2 receptors. At alpha 1 cardiac receptors, it has negative inotropic and negative chronotropic effect. At alpha 2, it causes peripheral vasodilatation and coronary vasodilation. Also, adenosine it activates the acetylcholine sensitive potassium channels in SA and AV node. Another action is decrease in calcium current. So what happens is there is marked hyperpolarization and suppression of calcium dependent action potential. Whenever adenosine is given in rapid IV bolus dose, it increases the effective refractory period of the AV node and decreases the conduction. And there is another special point about adenosine is that it has a very less effect on SA node. So mainly its effect is concentrated on the AV node, and as a result what happens is conduction through AV node it is reduced. Depression of reentrant circuit through AV node, it is also through AV node is responsible for termination of majority of PSVTs. This is and as a result what happens is PSVT in patients of PSVT adenosine it has emerged as drug of choice. Now in patients of PHK it is not effective orally. T half life is only less than 10 seconds. Now because its T half life is so short, it has to be given as rapid IV bolus doses. If we give like slow IV dose, then the drug will actually get metabolized before reaching the
पीछे
हाँ?
और पीछे
और कितना पीछे? किसी से बात हुई क्या?
हाँ
किससे?
एक मिनट बात आप बताओ कब हेलो आप बताना मैडम को कहाँ से बताओ बोलो अब दिख रहा है आपको
हाँ मेरी बात कर रहा हूँ. हेलो. हाँ आप ये बता सकते हो कि मतलब कौन से टाइप इससे हाँ हाँ
जो लास्ट लेक्चर खत्म हुआ टाइप 1A एंड टाइप 1B हुए थे.
हाँ हाँ
उसके बाद टाइप 2 शुरू करना था आज हमने.
हाँ हाँ तो मैंने टाइप 2 से ही शुरू किया था. मतलब वो
टाइप 2 3 आपने अभी जब शुरू किया फिर टाइप 4 से लाइव हुआ है.
अच्छा उससे पहले लाइव ही नहीं हुआ है.
नहीं लाइव ही नहीं था.
अच्छा चलो ठीक है, मैं एक काम करती हूँ अभी.
क्या
मैं टाइप रुक जाओ, मैं टाइप 2 से दोबारा एक बार शुरू कर देती हूँ, ठीक है. फिर उसके बाद टाइप 4 कहाँ तक हुआ, रुको. सारा ही ऑलमोस्ट रिपीट करना पड़ेगा. चलिए ठीक है कोई बात नहीं, मैं रिपीट कर देती हूँ. Okay.
आपको पढ़ाने टाइम है, मेरे पास क्लास नहीं है दूसरी।
नहीं है ना क्लास
ना ना,
दूसरी?
ठीक है, पढ़ाइए।
Okay, I think there was some technical glitch. So I'll be starting this again. Let's start with class 2 drugs, that is beta blockers. Now, first of all, mechanism of action of beta blockers. Now, we all know that beta blockers, they decrease the sympathetic tone. As a result, what happens is SA nodal atomicity, it is decreased. So basically impulse generation, it is reduced, right? Apart from this, what happens is AV nodal refractoriness, it is increased. So the conduction of the impulse, it is also decreased. Now, because of decrease in AC nodal atomicity, it provides a protection against adrenergically stimulated ectopic pacemakers, right? And because of AV nodal refractoriness, or because of delay of impulse conduction through the AV node, it prevents the reentrant tachycardia at this site. Also, class 2 beta blockers, class 2 antiarrhythmic drugs or beta blockers, they are useful for a range of supraventricular tachycardias, right? So basically, conduction is reduced and impulse generation is reduced, right? Thirdly, beta blockers, they can favorably influence arrhythmias by decreasing the workload on heart and improving the oxygen and demand relationship. So overall what happens is that beta blockers, they can prevent recurrent infarction and sudden death in patients recovering from acute MI, right? Now, what are the uses of beta blockers? Beta blockers are, first of all, is sinus tachycardia. Normally, what happens is patients with sinus tachycardia, they do not require any treatment. But if the need arises, we can give propranolol and esmolol in these patients. Also, emotions and exercise induced ventricular tachycardia is another indication for beta blockers. Apart from this, treatment and prophylaxis of PSVT. Although adenosine is the drug of choice for PSVT, but yes, for prophylaxis and treatment, uh, this has important use. Now, atrial flutter and fibrillation to control ventricular rate and to ventricular rate by decreasing the AV conduction. See, since the AV conduction is being reduced drastically, we can control the atrial flutter and fibrillation in these patients. Also, digitalis induced ventricular arrhythmia, pheochromocytoma, along with pheochromocytoma, thyrotoxicosis, and arrhythmias that are present during general anesthesia. For all these things, beta blockers are an indication. Now, what are the adverse effects of beta blockers? The most common adverse effects that kind of limits the use in patients with atrial fibrillation and flutter is negative inotropic effect. Second, it is negative chronotropic effect. So ultimately what can happen is AV block can happen, sinus bradycardia might happen, and myocardial depression might take place. So basically whatever these side effects are, they are usually seen when we give an overdose of these drugs. So you from these last three side effects, you can see that they are actually an exaggeration of their mechanism of action, right? So whenever we give a higher dose that is than required, then they will lead to exaggeration of the normal actions of these drugs, and as a result we call them adverse effects. So dose monitoring or calculating the dose requirement for these drugs is very important. Now, let's discuss the third type of antiarrhythmic drugs, that are potassium channel blockers. Amiodarone, sotalol, and ibutylide are the three drugs that we'll be discussing amongst this category. So, first of all, the main mechanism of action, as the name suggests, is potassium channel blockage. Now, as a result, what happens is repolarization, it is increased. So, if you have a look at the graph that we have discussed in the previous lecture, you can see that the slope of phase 3 or the phase 3. Basically this phase 3, it will be prolonged and phase 3 will be extended. Now as a result, what happens is action potential duration, it will be increased. The refractory period of the myocardial cells, AV nodal cells, and apart from this anomalous pathways as well, it will be increased. So because of this reason, potassium channel blockers, they are also given in WPW syndrome because they have an effect on anomalous pathway, and we know that in WPW syndrome we have an accessory or an accessory anatomical pathway through which conduction is happening. So to block that, we give potassium channel blockers. Also potassium channel blockers, they are effective in both atrial and ventricular tachycardia. Please excuse me. Now, let's discuss these drugs in a little bit of detail. Now, the first drug that comes is amiodarone. Now, if we have a look at amiodarone has a wide range of mechanism of actions. It is a potassium channel blocker, it is a sodium channel blocker, calcium channel blocker. Apart from this, it has alpha and beta blocking property as well. So because of this, it has a broad spectrum of cardiac actions, unusual PHK, and is important extracardiac effects. It is effective in chronic as well as recurrent ventricular arrhythmias. So this is a special point, that in patients who keep on having ventricular arrhythmias over and over, or who are a case of chronic ventricular arrhythmias, we give amiodarone in these patients. Also in patients with atrial fibrillation, it slows both the ventricular rate and may restore the sinus rhythm. So first of all, it will control the ventricular rate. Secondly, it will take the heart towards the normal sinus rhythm, right? So in cases of atrial fibrillation, amiodarone is of specific importance. Now amiodarone, it can be, since it can help in bringing up the normal sinus rhythm, it can also be used to maintain sinus rhythm in patients with atrial fibrillation who have recently undergone cardioversion, right? So it is currently the most effective drug available for PSVT that is associated with WPW syndrome, right? Although radiofrequency ablation is preferred and is the I would say cure for this thing, but if we have to give a drug, then we will obviously prefer amiodarone. It is highly lipophilic and it gets concentrated in many tissues. Its elimination is very slow. T half life although is very long, around 52 days, and onset of effect is late. Also it has an active metabolite, so its action, it stays for a long time. Now toxicity, it might lead to bradycardia, heart block and ventricular arrhythmias, coronary microdeposits, photosensitivity, hepatic dysfunction, hypo or hyperthyroidism. Because see, amiodarone, it has an iodine moiety present into it, because of which it might affect the thyroid function of the patient. So as a result, hypothyroidism or hyperthyroidism might happen in these patients. Pulmonary fibrosis, which can be progressive and fatal, is another important side effect that has been seen with it. Also, it potentiates the effect of warfarin and digitalis. So as a result, the doses of both warfarin and digitalis should be reduced when they are combined with it. Also, it should never be combined with quinidine. Now, our next drug is sotalol. Sotalol is basically a beta blocker, and also along with that, it has a potassium channel blocking activity. It has oral bioavailability of around 100%. Also, it is approved for life-threatening ventricular arrhythmias and for maintenance of sinus rhythm in patients with atrial fibrillation. For also, another important use of sotalol is that it is usually given to children who have ventricular and supraventricular tachycardia. So, if you see overall, this is the only drug that can be safely given in the pediatric population. Now, another drug is britailium. Basically, britailium, it is an adrenergic neuron blocker. It is used in life-threatening ventricular arrhythmias like VTVF in intensive care facilities only. Severe postural hypertension, nausea, vomiting are the major side effects. Now, because of severe postural hypertension, whenever we have to give this drug to a patient, we try and shift patient to the intensive care facility so that this postural hypertension, it can be managed promptly. After this, ibutilide is basically a structural analog of sotalol. It is rarely used now because of its potential to cause TDP. It requires continuous ECG monitoring. So these are the few limitations of ibutilide. So as a result, what we do is we prefer sotalol. Apart from this, another drug is dofetilide. Dofetilide is reserved for the treatment of atrial flutter and fibrillation. This is also associated with risk of developing TDP. Now, newer class 3 drugs. First drug amongst the newer class 3 drugs is drondaron. Drondaron, as its name suggests, it's an amiodarone-like drug. But the benefit of giving this drug is that, first of all, there will be no thyroid-related problem. Secondly, the pulmonary fibrosis, which was a fatal prominent progressive pulmonary fibrosis, which was a fatal prominent side effect of amiodarone, that is not present with these drugs, because this drug, it is without any iodine atoms. So as a result, these side effects are not present with drondaron. It has a short T half life, that is around 2 days, and can be administered twice daily. It reduces the mortality in patients with atrial fibrillation. So, and it is also used to prevent atrial fibrillation recurrences in patients with persistent atrial fibrillation. Now, another drug is teddisamil. Teddisamil is basically a novel class 3 agent uh, which is actually under study for conversion of atrial fibrillation AF to AFL to normal sinus rhythm. So basically, this drug, it has a two-step mechanism. First AF to AFL and then to normal sinus rhythm. Third drug is vernaculant. Vernaculant is basically a sodium and a potassium channel blocker. Like the other antiarrhythmic drugs, it is also used for treatment of atrial fibrillation. What it does is it prolongs the refractory period of the atria and slows the conduction through the AV node. Ventricular ERP or ventricular effective refractory period is unaffected with this drug. Its association and dissociation with sodium channels is faster. Hence, it is more effective in patients with tachyarrhythmias. And one important point of this drug is that it is contraindicated in patients with congestive heart failure and patients who have had a recent episode of MI. Another important drug is azimilide. Azimilide, it blocks both rapid and slow components of the potassium channels. So as a result, what happens is phase 3 is prolonged, refractory period is prolonged, action potential duration is prolonged. This drug is under investigation for converting atrial fibrillation into sinus rhythm. Now, I think we have discussed some of the slides from calcium channel blockers. So I'll be skipping those. Adenosine, I think we had not completed. Okay, we did complete. We were somewhere here. Okay, so see, adenosine, as I discussed earlier, basically we have, because of its short half-life, very short half-life, we have to give it in rapid IV bolus doses, right? And that too through a large central IV line. If we give it in slow dose or slow IV dose, drug will not be able to reach at the heart. Basically, it will be metabolized before even reaching the heart. So the whole purpose of giving this drug will be defeated. So IV bolus, rapid IV bolus with large central line, we have to give it, right? So uses, basically it is used to terminate AV and RT, and it produces AV block that lasts only for a few seconds. But since only this block lasting for a few seconds is enough to actually decrease the cardiac contractility, decrease the conduction, right? So its short half life, block of few seconds is enough for its effect. Okay, now the doses. First dose that we give is usually a bolus dose. We give 3 milligram over 2 seconds. If no effect is seen, then we double the dose and give it after 1 to 2 minutes. If still no effect is there, then we give 12 milligram dose after 1 to 2 minutes. The side effects that have been associated with this drug is breathlessness, chest pain, flushing, bronchospasm, transient invariable side effects. Now, the important thing about this drug is that all its side effects, they are very transient, they are short living, right? So even if all these things they happen, they last for a very short time. But yes, this side effect of breathlessness, because of this thing we always avoid this drug in patients of bronchial asthma. Now, interactions. First of all, its effect is greatly potentiated by dipyramidol because it is a reuptake inhibitor. So, whenever we have to give it with a dipyramidol, we reduce its dose. Secondly, its effect is blocked by xanthines because xanthines, they are adenosine receptor blockers. So the best thing would be to not to combine these two drugs. Now, therapeutic drugs, as I told you earlier, that it is the drug of choice for PSVT. Now, what made it as a drug of choice for PSVT? First of all, it is very efficacious in patients of PSVT. There is no negative inotropic effect, and whatever side effects that occur, they are very transient. Also, this drug is used to induce brief coronary vasodilation during certain interventional procedures to produce controlled hypotension during some surgical procedures to allow less loss of blood. So we basically induce a controlled hypotensive state so that there is less blood loss. It should be avoided in patients with asthma, like I told you, because it leads to breathlessness, second and third degree AV block, recent MI, unstable angina, sick sinus syndrome, right? So all these uh, side effects or all these diseases are basically contraindications for adenosine. Now, magnesium sulfate. Magnesium sulfate is basically very effective in terminating life-threatening refractory ventricular tachycardias including TDP. It is helpful in treating digitalis-induced arrhythmias that are associated with hypomagnesemia. So, see what happens is digitalis, it causes hypomagnesemia, right? So, as a result, when we give magnesium sulfate, so the arrhythmias that are induced by hypomagnesemia, they get terminated. Usual dose is usually 1 gram IV over 20 minutes, and if required we can repeat the dose once again. Now, treatment of different types of cardiac arrhythmias. First of all, sinus tachycardia. What is sinus tachycardia? It is usually a heart rate of 100 per minute, and rarely 200 per minute is also known as sinus tachycardia. Usually this does not require any treatment, but if treatment is required, we usually prefer beta blockers, that is propranolol. Now, sinus bradycardia, when heart rate is less than 60 per minute, it might be because of drugs like propranolol, verapamil. So, if this patient is symptomatic and if this patient has hypotension, what will we do is we will give atropine IV, that is 0.5 to 1 milligram, isoproterenol, and cardiac pacing. It can be done. Now, atrial fibrillation. In patients of atrial fibrillation, heart rate is usually around 600 per minute, and in patients of atrial flutter, it is half of it, that is around 300 per minute, with AV block 2:1 or 3:1 and corresponding ventricular rate of 150 to 100 per minute. In patients of atrial flutter and fibrillation, we first of all we see whether the patient is hemodynamically stable or no. If the patient is hemodynamically unstable and compromised, then don't think, just give IV heparin to the patient, and after that direct cardioversion, right? If the patient is hemodynamically stable, now here our goal will be to control the ventricular rate. So we can give digitalis, calcium channel blockers, or beta blockers. Another alternative is flecainide. Now, once this ventricular rate has been controlled, we can put patient on the maintenance dose of sotalol, amiodarone, or disopyramide or flecainide. So For prevention of thromboembolism, we can put this patient on warfarin. First, we give heparin, then we can shift this patient onto warfarin on the oral anticoagulant, right? So, for in patients of atrial flutter, if we have to control the ventricular rate, we have to give digitalis calcium channel blockers and beta blockers. For restoration of sinus rhythm, we can either go for DC cardioversion depending upon how severe is the flutter, or we can go for drug therapy, that is amiodarone or flecainide. The previous drug therapy that I have discussed here, it is basically for atrial fibrillation, right? And for uh, atrial flutter, it is this: we control the ventricular rate and we try to reduce the normal sinus rhythm. Now, AVRT or WPW syndrome, that is Wolff Parkinson Wolff syndrome. In this condition, basically what happens is that there is an anatomical accessory band which connects the atria and ventricles, and it can electrically bypass the AV node. So, normal sinus rhythm, the conduction is partly through the AV node and partly through the bypass tract, and this bypass tract, it is more rapidly conducting as compared to that of the normal tract. As the AV node and the bypass tract, they have the different conduction speeds. What happens is a re-entry circuit can develop. Because of this, paroxysmal tachycardia might occur, and even atrial fibrillation with WPW syndrome, it can be seen, right? So basically, the best treatment, or I would rather say the best cure here, would be to ablate or radio frequency ablation of these pathways. Apart from this, what we can do is, for prevention of a prophylaxis, we can give flecainide, sotalol, and amiodarone. As I've discussed earlier, sotalol, amiodarone, flecainide, all these drugs, they have an effect on the accessory pathways. They can block the accessory pathway, right? So this is how they prevent the attack. Digitalis and verapamil, they are contraindicated in patients of WPW syndrome. DC cardioversion may be required to restore the sinus rhythm when ventricular rate is very very high, right? So basically, depending upon the ventricular rate of the patient, we have to decide which line of treatment we have to follow. But yes, digitalis and verapamil, they are absolutely contraindicated in these patients. Now, ventricular tachycardias. Ventricular tachycardias, basically they require urgent treatment because they frequently lead to ventricular fibrillation and ultimately cardiac arrest or circulatory arrest. If the rapid hemodynamic deterioration occurs, we go for cardioversion. If the patient is hemodynamically stable, we can give IV lignocaine or IV amiodarone. For recurrent ventricular tachycardias, amiodarone or sotalol is preferred. Now, for these patients, another thing that can be done is that implantable cardioverter defibrillator, it can be placed. So this cardioverter defibrillator, it will defibrillate the heart whenever it is required. For TDP, we need to give IV magnesium and IV isoprenaline. So whatever I have discussed, basically I have given it in the chart form as well. So for the summary purposes, you can read it from here. The same is here. Every arrhythmia, along with that, what drugs are preferred, and what are the drugs that are commonly given in all these arrhythmias that I have given, right? Same. So this is basically for so that you can keep them in mind easily. So you just see, and in all these arrhythmias, you basically have to remember the mechanism of action and side effects, and what are the contraindications, drug interactions. These things you have to remember clearly. These are usually asked either in your viva or maybe in your exam as well. And please go through this topic very well. This is an important topic and a potential question for your exam. So if you have any doubts, so you can contact me on my email ID. You can send me a mail. My email ID is priyankaloch@gmail.com. PRIYANKALOACH@gmail.com. Thank you.